So what are these things? All these things that come to is that there are some fundamental questions that vets need to ask themselves and that you are entitled to ask your vet. What are they doing to prevent primary diseases? Third world diseases, infectious diseases, ticks, fleas, skin problems that arise from those things, injury. What advice are they giving you that helps you prevent avoidable problems? And some of those include non-medical problems like financial issues. We advise and advocate medical aid very, very aggressively. You know why? Because when there is a problem, the clients and I are discussing the medical facts, the prognosis, and what needs to be done. And we are not beholden to the financial limitations of the client. Okay? That is a really useful thing. We prevent regional problems. I'm going to talk about herd immunity, and we advise clients in advance, and I think I've touched on that. So I'm going to use rabies as an example. That 20,000 people die every year in India as a result of rabies. In South Africa, in my province alone, 37 people died this year. But Limpopo province, which can't deliver school books, has crumbling water infrastructure, and is generally the basket case of our country, has 0 cases. Why? Because the one thing they've got right is they have a 98% vaccination rate year on year, local government sponsored to vaccinate against rabies. What's the vaccination rate in KwaZulu-Natal? 4%. And that's rabies. I mean, that's a human illness. Rabies is not a dog disease. Dogs are part of the life cycle. Rabies is a human illness that less than 10 people have survived since it was first documented by the ancient Egyptians. Okay? This is a terrible problem, and yet we shouldn't be dealing with it. And I'm going to illustrate what that means through the concept of herd immunity. So the starting point is that you only have to vaccinate 50 to 70% of dogs every year in a community to eliminate rabies. You don't even have to vaccinate 100%. People have shown that you cannot eliminate the feral dog populations. Okay? We'll explain that. And you cannot get rid of it in wildlife unless you're going to wipe out all your wildlife. I'm half Italian, and you go into Italy, into the countryside, and you don't hear a bird. Because the Italians are very avid hunters, and what they've done is they've shot everything from a butterfly up. Now they have no wildlife, so they have no rabies. Okay? Countries like ours that have a lot of wildlife, we have, which I think is right, we have this problem. But the wildlife is not the big issue. So there's this concept of herd immunity, and that if you vaccinate a significant portion of a population or a herd, whether a herd is dogs, cows, people, whatever, you create immunity not only for the vaccinated individuals, but also for the individuals who cannot be vaccinated, who have not responded to a vaccine, or whose immunity has declined as a result of age, disease, treatment, nutrition, whatever. Okay, it's not just about the vaccinated people and animals. So how does vaccination work? So all diseases have a basic reproductive number, R0. And it's the number of secondary cases that an infected individual creates. And it determines whether disease persists or dies out. So if your R0 is normal or is 0, then you don't get any infections. Okay? Cancer has an R0. I could have cancer. You can't get it from me. There's no way you're going to get it from me. It's not an infectious disease. We're talking about infectious diseases. So let's say we have this population. Whoa! Sorry, hit the wrong button. Not ambidextrous. And you introduce one infected individual into this population of susceptible, unvaccinated individuals. Now, this disease has an R0 of 2, for argument's sake. I'm talking about a theoretical disease. And it means you get 2 secondary infections, and they create 2 secondary infections, and they create 2 secondary infections. And what you get is what's called exponential growth. And that's what it looks like when you look at the population. And this is how an epidemic occurs. Okay, so now if you have R1, each infection creates 1 infection. Now, you may not be cured of this by transmitting it, but it means that your numbers do go up, but not in a logarithmic, but in a linear fashion. If the R0 is less than 1, the disease goes extinct. And there are diseases that are very difficult to get. They're not very contagious. As soon as you introduce, and I realize blue is probably not the best color, you vaccinate some individuals, you reduce the number of available, susceptible animals in a population, And what happens is you change the R0 of that disease. It becomes less able to transfect. And so what happens is it blocks. Some of these diseases, see here, they just die out. They go to zero. And this, when it gets here, you're starting to run out of patients. Now the problem is, I mentioned you can't get rid of wildlife entirely. So you can't get rid of all the reservoirs and all the feral dogs. And the problem is that rabies can persist at a very low animal density. But it can also cause an outbreak at a relatively low animal density. So that margin for error is very, very small. And therein lies our challenge. So we need to say, okay, so what about these R0s? Why did I tell you about this? Well, if you want to understand the critical vaccination percentage, you use that R0. So if you have an R0 of 2, you need to vaccinate 50% of animals to really eliminate a disease. If you have an R0 of 10, a very infectious disease, one infected individual creates 10 infections in susceptible individuals, you need to vaccinate 90% of individuals on an ongoing basis. So let's look at some examples. Foot and mouth, 9.8. Rinderpest, 4.8. Measles in humans, 10 to 15. Very contagious. Polio, 5 to 7. All of these diseases controlled through vaccination. Some of them eliminated. Okay? There's the proof that vaccination works. That's how disease works. That's how vaccination works. So what's the R0 for rabies? How big is our challenge really? Anyone want to guess? No guesses? 4, 7. 1.1. Okay, we'll get some motivation in a sec. Some perverse incentives coming your ways, ladies. Okay, so R0 is very low. Rabies is actually not that, it's quite an infectious disease once you're in contact, because the dogs don't wander very far. Okay? And they don't readily transfect or infect other patients. That means that we actually could eliminate this disease quite readily. So we only need to vaccinate 20 to 40% of patients, of susceptible individuals, to eliminate this disease. So we call it 70%. Why? Because as time goes, you start to lose individuals that are vaccinated, and other individuals are recruited because the dog population grows by 8%. And the example of this is human behavior, this isn't science, is that what happens is you start to get rabies cases, then you have a vaccination campaign. Oh, yeah, and there's a big rage because somebody's child dies or somebody's dog dies and from rabies. And then people start to forget, and then you get a few cases, and it's human nature, big panic. This is not the way to control a disease. Okay? It's big vaccination campaigns sustained year after year, generation after generation. Then we will eliminate. Who gets vaccinated against smallpox anymore? Nobody. Why? Because of the effort, not because of the seesaw approach, because of sustained approaches and evidence. Okay, I'm not going to bore you with those stats. A part of pet healthcare, which does come into vaccination, is the pet identification. Our goal in my practice, we've set ourselves a goal for end of 2020, is that we want to have 100% of our patients in our practices microchipped. So that if they are lost, we maximize, we can't guarantee, but we maximize their chance of getting back to their homes. But if you think about it, if you try and get a dog into Australia or to the United Kingdom, you can vaccinate it perfectly. But if they can't identify that individual, oh, he's a fluffy brown dog, well, that's not helpful. Oh, he's got a microchip implanted in his skin. This individual and that vaccination card are tied together. You're never going to succeed. In the UK now, they're introducing a law making microchipping mandatory. That is a great approach. Okay? If you're recommending microchipping, you need to know that the call center and the support mechanisms behind there are good. There are a lot of crap microchips that have come into South Africa over the last 5 years. Animal gets scanned, the microchip can't be scanned with the regular scanners, or you phone and there's no call center. So like, what you may as well have put a kernel of rice or under the dog's skin, or pushed a piece of amethyst up its bum. It's not going to help locate. So we attach our reputation to the microchip we choose, which is why our practice pays a little bit more for a really good microchip. It has a good backup system in South Africa, 24/7 call center, modifies the reports constantly as people change their ownership. I'm not going to go into pet medical aid more than I have. And we've talked about health surveillance and doing regional things. Well, one thing I will say is that we as a practice create packages. So we say, if you get this package, like senior health profiles, we subsidize it a bit. And the medical aids actually pay for this. And suddenly when clients get a full medical package, like the one that I talked about, cats and dogs, and it's covered by the medical aid, they bring their dog every year. When it gets really old, geriatric, they bring it every second year. You know what happens? 25 to 30% of the time we find an abnormality before it becomes a crisis. We treat it then, we address it, we change a lifestyle, we change a diet, we put the dog on a weight clinic, we deal with the teeth to clean them rather than removing teeth every year, and the dog ends up with fewer and fewer and fewer teeth. And removing teeth is painful and it's an unnecessary anesthetic. We pick up problems early this way, and what we do is we encourage people to bring their pets in early. So where is this all taking us? You know, you've heard talk about the fourth industrial revolution. How does that apply to pets? How does that apply to vets? I mentioned a little bit about that collar. You know, I can keep in touch with my pets at home. I have, on my cell phone, I have a program. The clients can create a confidential medical record. They can contact me. I've had a client this morning where I've checked and she's taken her dog's blood glucose at home, and she has sent that to me, and I'm telling her how to adjust her insulin accordingly. We don't have to get a dog into the clinic. Now, Joe, at the back there, Joe's got a couple of things he's going to send around. I'm just checking my pockets for one of them. He's going to send 3 little devices around that can circulate. Please bring them back to me. They're all expired, so you're not getting anything for free if you keep it. But there's a little white disc about the size of a 2 Rand coin. That is the next level. That is a glucose monitor. It sticks onto the patient. You'll see there's a little silicone catheter on the back. We just press a button, shave a patch on the dog's leg, dog's back, press it, it sticks onto the dog or cat. The owner gets a special reader. They press near that every day, at least once every 8 hours. It's recording a glucose measurement every 2 seconds. They go to their computer, they press a button, it sends the full glucose curve to me. It lasts for 2 weeks. I'm able to stabilize diabetics at home without them ever coming in. It's cheaper than coming in for repeated blood glucose measurements. It's less stressful. It's more accurate because there's no travel and stress. The German Shepherd around the corner is barking and this cat's sitting there and its glucose is going high. That is using technology to help a patient. Okay. Another one we've got is this. This is a camera. It's got 4 little cameras. It's got its own strobe lights, its own battery. And unlike the human one, it's a bit smaller than the human one. This is a veterinary device that the dog swallows. And I'm going to show you some pictures from one of this. And tells me everything that's going on in the entire gut. Okay? Now I don't need to anesthetize a patient. There's also a little thing that looks like a miniature flash disc with some little, it's slightly barbed. It's an ECG that gets planted under the dog's skin in a small procedure with some local, 1 stitch to keep it in. Lasts 3 years. Whenever the dog comes in, I have a monitor, I push it down, it downloads all the information and resets it. But it goes another level up. When Joe came to see me in South Africa in the beginning of the year, I do all the cardiac monitoring for the chimpanzees at the Jane Goodall Institute in Nelspruit. And we planted one under a chimp's skin, and he's got a little monitor that sits outside his cage, and every time he's within 5 meters of it, it downloads it and emails his whole ECG to me, same device. I don't even have to travel up to Nelspruit to go and look at it. And we're monitoring him for heart disease. So there are all sorts of things that are amazing. But these technologies help us help animals. Animals that are companions live with people. They're part of a family unit. They're part of an ecological unit of health and disease, including mental health for some people. And I'm not being disparaging. I'm saying animals contribute to good medical health, or for some clients, they contribute to worry, which is bad medical health. And there's this concept out there, it's been around for about 15 years, of One Health, that you cannot separate veterinary health and veterinary patients from human health. And that includes the food chain, that includes disease prevention, infectious diseases, all of these aspects. And more vets are involved in human health by keeping the animals healthy. And you need a vet who's sympathetic and understands and buys into that concept. They don't have to give you, any personal medical advice. That's not what I'm talking about. I'm not a doctor. What they're doing is they understand their contribution to societal health and well-being through their contribution in an animal's health. That is very important, and the whole conference is around it. So the medicine is just subsumed, and the technology is subsumed into part of that. So what is the future of medical care? The future is targeted therapies. Okay, we have products like Cytopoint and Apoquel that I gave a dog a course of Apoquel 2 weeks ago, and I gave the first tablet in the consult room. The dog has a 4-year history of chronic skin disease. It's had desensitization of allergens, it's had homeopathic medicine, it's had cyclosporin, it has special diets, it's on good flea control, and it's a guide dog. This poor dog cannot stop, it can't walk across my waiting room without scratching. And it belongs to a blind man, so you can understand the problem. By the time they got home, this dog had stopped itching. That drug targets the one chemical that triggers itching and redness. So it doesn't have the widespread effects of cortisone on all the body systems. It works quickly and has fewer side effects. It's targeted therapy. Palladia and Massivet are chemo agents in tablet form developed for animals. Massivet is used just for mast cell tumors, the second most common tumor I deal with. It doesn't require nearly the same monitoring. It doesn't have nearly the same side effects as the traditional chemo and has equivalent efficacy. And it's a tablet. The client gives it at home. And because it's not a chemo, we don't have to worry about the client's exposure to this chronically. And it blocks a receptor that you only find in mast cells and one very particular rare gut tumor. The next thing is that we have gene therapy. I'm very good friends with a guy named Phil Bergman, who developed with a team of people a melanoma vaccine. So let me tell you about melanoma. It's one of the nastiest malignancies of dogs. Okay? Oral melanoma, melanoma under the nail bed, these are terrible diseases. Whether you do chemo, radiation, surgery, or any combination, the average survival time is 90 to 110 days. You can spend 40, 50, 60,000 rand or 5,000 rand and get the same outcome. Okay? And without treatment, once they're diagnosed, they're usually dead within 6 weeks. The melanoma vaccine infects the dog with the human tyrosinase gene, which produces melanin, but the melanin and the tyrosinase are just different enough from the dog one that the immune system says, wait a minute, what's this? And then it wipes those cells out, and then it says, well, where else? That's why it's a vaccine. It's a biological response modifier, and it finds that tumor and it destroys it without inflammation. The average survival time, 389 days. For stage 3 melanoma. That means it's already spread to the lymph node. That's the average survival time. We have dogs. My very first dog that I treated with melanoma lived 7 years and died of a different disease. Okay? Side effects? 0. That's actually not true. The original study that 140 dogs, 2 were black Labradors and their coats lost some color and then regrew. That was the worst side effect they had. That is what science is delivering to us. It's one injection into the thigh 4 times over an 8-week treatment, and then a single injection every 6 months. And that's it. No blood monitoring. We've had 25% of dogs where the tumor has already spread to the lungs, where those lung tumors have disappeared. And we used to think, hey, metastatic disease to the lungs, that's tickets. The next thing that they're going to be doing is they're going to be taking CRISPR technology, and they'll say, oh, your dog has this genetic disease, like the Doberman. We know the gene because we've mapped the canine genome. Now what we're going to do is, that gene is defective in your Doberman. We're going to correct that gene in your dog. Your little Doberman's going to come in for its vaccinations. It's going to have a blood test or a cheek swab as a puppy. And by the time it comes for its second vaccination at, say, 10, 11 weeks of age, you have a report and it'll say, these are the health issues of your dog. We're going to correct its genes. That will probably come at the end of my career. But who knows at the rate of science. 20 years ago, I wasn't using a cell phone. I was using a Commodore 64, and I thought that was pretty neat. So things have changed, and that is where we're going. You may be able to modify breeds. Is that ethical? Would it be ethical to deny them genetic modification that corrects some breed-associated diseases? Do we actually have an English bulldog anymore if it does no longer has a long face? I mean, a short face, but has a slightly longer one? Who knows? These are problems for somebody else to figure out. But and then we also really have some other amazing technology. So let me show you an example. This is a Yorkie with a collapsing trachea. I do almost all the tracheal stentings in South Africa. This procedure takes me under 3 minutes. It is no cutting. We use a device to introduce a nickel titanium stent into the airway. Poop, pops it open. Dog comes in blue and wanting to die. Dog goes home the same day, breathing normally. Look, it's going to have a mild cough for the rest of its life. And the learning curve for this technique is, to put it mildly, very character building. But it is a very important life-saving technique. Okay, it's a palliative procedure. It would be even better if we could correct the genetic defect in the cartilage of the rings of the trachea with gene editing. But that's coming. But between now and then, we can do a hell of a lot more than we could do 20 years ago. Now I'm going to show you a neat technique. I actually went to Spain to do the very first course of this a few weeks back, but we've already been doing this with the help of a human radiologist. This dog had a thyroid tumor. The tumor had had 3 courses of chemo, had not responded. It was inoperable because of its involvement of other tissues. We had irradiated it. It had worked for a while, and now it had come back. Now what do? The dog is now having trouble breathing and swallow. We introduced a catheter into the groin, fed it all the way up to the carotid, up to the blood vessel supplying the tumor. You can see it there. I put little dots on it. That's a big blood vessel. And then through that, and through a catheter, inside a catheter, we inject latex microbeads, which destroy the blood supply of the tumor. There's the tumor and its blood supply. That's where it was. See? Gone. You'll see that? We also inject a contrast agent, and we can now see the tumor. So I'm going to take this away, and you can see we've now put contrast into the tumor, so it's a little bit more visible. See the tumor? That was the edges of the tumor. Now we know that we have blocked off the blood supply, but that blood vessel there, we've left unaffected. And this dog had another 4 months, pain-free, no consequence. And then when the tumor popped up in his chest, we said, hey, listen, okay, but this procedure took us about 30 minutes and involved 1 incision over his groin. So these things can be done. This is a really, we see a huge number of skin cancer because the Americans with their big gas guzzlers have made a hole in the ozone layer over South Africa and Australia. So this dog had 5 surgeries for skin cancer, including having its penis amputated, wheezed through there, like a girl, and then is presented to me like this, with not 1, but 3 different tumors, a melanoma, hemangiosarcoma, and a very big set of squamous cell carcinomas, including down the leg. And now I'm presented with this patient. Now, I should have seen this patient right in the beginning, when the tumor was just starting. Okay, you all agree? And that comes from the owner, but the owner's in the vet's hand. He doesn't know. The vet should have known. And this is not a vet that doesn't know me. This is a vet whose clinic I go to every month. I run my satellite clinic from there. I see patients in Umhlanga once a month. And so he could have just asked me, hey, Ant, I've got this case. What do you think? So the only way we managed it, giving it a course of chemotherapy, giving it a course of radiation, getting it to a point where it was small enough that my assistant could do a 4-hour massive surgery. Yes, it was successful. Did it need to be done? No. That's not the way I want to make a living, guys. And again, that's not a way your vets should be wanting to make a living. The key here, prevention, awareness. Awareness starts with education. Education starts with the vet telling you. The vet can only tell you if they know about this. They can only know about it if they continue to educate you and educate themselves. And sometimes that education becomes because clients are nagging them. Clients present them with evidence. This is being done overseas. There is no reason that the vets in this country cannot do those things. If we can do it in Africa, I mean, crikey Moses, guys, you can do it. I showed you that picture with that bright orange light, right? We're coming to an end now. So this is a dog with a squamous cell carcinoma. That is a very tricky spot to operate in, because you want to get a margin of healthy skin, but We don't want to end up like that previous dog. The second thing is all of the skin here, except the black spots, has received the same amount of radiation. And this is why surgery as a conventional treatment for skin cancer often fails. Because you cut this out, and 1 millimeter to the side, on that, the skin cells that remain in your incision or next to your incision or a centimeter from the incision, they receive just as much UV radiation. They're just on a slightly different time scale. You know, the trains don't always arrive at the station when they're supposed to. And so you see it as a failure of the prior surgery. It isn't. It's a failure of the decision making. So if these are very big, we'll cut them out. But then as soon as they've healed, how do we manage that? We do photodynamic therapy, the application of a cream that is sensitive to a very specific wavelength of light. We apply that cream to the affected areas. We put the dog in a cage for 4 hours, darkened cage, so you don't get premature activation. The cream is absorbed into the tumor cells preferentially. It's quite neat because tumor cells are quite leaky. The cream, the chemical in there assembles into an unstable molecule. And then when you subject it to light, you see this patient's being monitored and the nurse is sitting there. She has special goggles. He's under anesthesia for 20 minutes, not the 4-hour surgery he did before. As what happens, that light activates the cream, the compound falls apart and generates what are called free oxygen radicals, which pretty selectively kill off the tumor. Do you want to see what it looks like? So that is about a week afterwards. That looks pretty sore. So we give painkillers before we start the procedure, and then for a week to 2 weeks afterwards, and we give emollient creams, and that is what it looks like a month afterwards. There were no tumors. These little things are not tumors. They are tumors on the way out, or they are small abrasions. This dog did not die of his skin cancer and required no further treatments. This cost 6,000 Rand. That other dog's treatment cost 70,000 Rand. Okay? And we talk about Brady. Brady was losing weight. We put an endoscope. We did an ultrasound. We did blood tests. We did x-rays. We could not find a reason why this dog was losing weight. He would go on and off his food, on and off. So we took the camera. We give it to him on an empty stomach. And these are the kinds of pictures we get. It looks pretty funny because there are 4 little cameras 90 degrees apart. So it scans all the way around as it moves through the stomach. You give it to him on an empty stomach, and 24 to 48 hours later, you're digging through his poo, wash it off. We put it into a little reader. It downloads all the images. So let's take a look. See these? Those are ulcers. There is a great big ulcer there. That has got to be sore. But why did he get these ulcers? Because he has a fibrous foreign object that I didn't see on the ultrasound. I'm not perfect. Ultrasound's not perfect. X-rays weren't perfect. The endoscope couldn't get that far down his gut. So we said, okay, this substantiates taking this elderly dog with his heart disease and saying, let's operate and remove it. And that's what we did. The technology allowed me to make a diagnosis in an individual that I would never have made by myself. I promised you a couple of pictures of dogs with halters. There's being put on. And in that device there is a chip. I put it into my computer. I download it and I get 120,000 heartbeats. And then I can quantify. This dog has 5,000 arrhythmic beats per 24 hours. That is below or above the threshold. If a dog is having fainting episodes, is it neurological? Is it cardiac? This is one way of knowing. Oh, there's no cardiological problems. It must be neurological. So we're moving from the old Frankenstein approach to dogs to a more advanced dog. And the future is about reducing risk through education, improving the efficacy of our treatments, making new diagnoses about or understanding diseases we never diagnosed before. You know, people say to me, "Oh, allergies are much more common these days. Is it the foods? Is it the?" So we didn't know that allergies existed in dogs, and when we did, we didn't understand. And then people started to understand house dust mites, pollens, how food allergies work, how they don't. And we start to get more and more knowledge, and there are people out there constantly asking new questions. The universe is infinite, and there's an infinite number of questions to be answered. It'll keep us busy for quite a while. But the important thing is that people are asking questions, and they're moving on to understanding them at the genetic level of the animal, which gives rise to new treatments that we can use, which means our pets are going to be for us very long. It's not going to be unusual to see a 20-year-old dog. Okay, I've already seen a 15-year-old Great Dane. My Great Dane's the oldest one, got to just shy of 11, which was unheard of 20 years ago. But that's because I treated her for malignant cancer that I would never have diagnosed or been able to treat when I qualified. And she was killed by an untreatable disease. Give us 20 years, we'll be able to fix that as well. And all of this leads to a closer integration of understanding the ecosystem of human, societal, and animal health, and the role that people and vets have to play in that. And what I'm saying to you, what I want you to go away with, give out good information, like some of the things I talked to you about vaccination now. Drive your vets to grow, and those vets who don't want to grow, move away from them. There's somebody who does want to grow, and support them and encourage their learning, and they will feed that back and keep your animal and your pet that you love so much with you for longer. Thank you very much.